Bismillah ar-Rahman ar-Rahim. It's truly a pleasure to be here, and I'm honored to be a part of this distinguished gathering. I would like to extend my sincere thanks for the organizing committee for inviting me to be a part of this great event. My talk is about image-guided breast intervention, biopsy, and beyond. Breast cancer is the most important cancer affecting women, and it is the second most cancer worldwide. Early diagnosis depends on early stage cancer detection, which could reduce breast cancer death rate significantly. The most critical point for early diagnosis is to identify early stage cancer cell. This would be done by different diagnostic modalities. Moreover, image-guided breast intervention have progressed well, making radiologists an important part of the multidisciplinary management of breast cancer. Image-guided breast intervention include breast biopsy, tumor localization, therapeutic intent, and palliative intent. Image-guided breast intervention is primarily composed of breast biopsy for the suspicious lesion, which is by RAD4 suspicious or by RAD5 highly suspicious on the imaging. According to the guideline, a non-operative diagnosis should be possible in the vast majority of invasive breast cancer, with a minimum standard of 90% of cases. Image-guided breast biopsy provide accurate biopsy for suspicious abnormality, reduce the need of repeated biopsies versus blind biopsies, and it leads to a steady decline in the number of diagnostic surgical biopsies over the years. Image-guided breast intervention have different modalities. Begin with the ultrasound, follows the ultrasound visible lesion with the real-time imaging and sampling. Followed by stereotactic biopsy for calcification and lesion not clearly seen by ultrasound, which is done by using special digital mammography with computer analysis of the X-ray at two different angles and coordinate them. This is the shape of stereotactic biopsy. DBT, or digital breast tomosynthesis, which is the same of stereotactic, but moreover, it provides pseudo three-dimensional image of the breast, leading to optimum visualization of the subtle lesion. And functional imaging, which include contrast-enhanced mammography and MRI, which allow biopsy for the enhancing only lesion which is better detected with contrast. So the final picture for the image-guided breast biopsy is ultrasound for the visible ultrasound lesion, stereotactic biopsy for calcification or lesion not clearly seen by ultrasound, and DBT, which is the same as stereotactic, moreover for distortion, and functional imaging for the contrast-enhanced mammography and MRI for the only enhancing lesion. Types of biopsy are important types. The most important is core biopsy, which is the most accurate and becomes the standard for biopsy of breast lesion. Automated 14-gauge core biopsy is the standard used. Another type is fine needle aspiration cytology, which is simple, less expensive, and less traumatic, done by 20 and 22-gauge needle, yet high false negative rate and cannot differentiate DCIS from invasive ductal carcinoma. Moreover, immunohistochemical analysis for hormonal receptor is difficult. Another important type of biopsy is VAB. This is a machine of VAB, which has probe with motor driving, allow directional sampling for more than part of the lesion, taking from 12 to 20 while rotating the needle 360 degrees. It is used for stereotactic biopsy and if pathological analysis is inconclusive. Another type of breast intervention is tumor localization. Early diagnosis and the rise in the new adjuvant chemotherapy help in changing the scenario of breast surgery from modified radical mastectomy to breast conservative surgery. The rise of breast conservative treatment highlight the role of the radiologist that become not only in diagnosis, but also in the management. Only confirmation after histopathology, further treatment is planned based on the hormonal receptor status of the tumor. With the newer improved chemotherapeutic agent, nearly from 20 to 25 patients may show complete clinical and radiological response to the new adjuvant chemotherapy. It mandates localization of the tumor site before or during chemotherapy, before the tumor vanishes completely. And this is done by using tumor clip. Clip is the spot for the breast. The clip serves as indicator for the future exam to show the doctor the area have been checked. It helps the radiologist to compare it with the previous mammograms and to follow up the response to chemotherapy. This is the shape of the clip, automatic clip on the right side, and the surgical clip on the other side, which is prepared and held by a holder, then introduced inside the lesion by spinal needle or cannula. Here is administration for entering the clip inside the lesion using the needle, which is entered till reaching the center. The spinal needle entered, and the clip is inserted, and then it is withdrawal of the needle, and the clip seen inside. Ultrasound image for lesion with the clip seen its center as a hypoechoic linear shadow. Mammographic image for the for the dense linear shadow of the clip inside the lesion. So pre-treatment or during treatment clip, then from 20 to 25 show complete response. Then the clip will be the only spot for localization of the surgery. But how the surgeon reaches the lesion? This is a new crucial step done by the radiologist, which is wire, which draws the way to the surgeon. Here is wire localization, with the wire its distal end is seen the lesion, and the other end is seen outside the skin. And surgical specimen shows the wire inside the lesion. It is done preoperative for localization of the small non-palpable lesion discovered during screening or rendered non-palpable after new adjuvant chemotherapy. Here is the needle. Wire is introduced through the needle by ultrasound or mammographic guidance. This is mammography for a patient with pathologically proven invasive ductal carcinoma, with the clip is seen inside the lesion. At follow-up study, the lesion is seen smaller in size, and as the last follow-up, it is vanished completely, and preoperative wire is seen at the site of the clip. New localization techniques include other modalities to reduce the complication of the wire, which include migration and hemorrhage, which are radioactive seed localization, which is introduced by ultrasound-guided and localized operative with handled gamma probe, or mega seed, which are paramagnetic steel and iron oxide dedicated sigma detector detect the seed during surgery. So both of them need probe during the surgery. Image-guided breast intervention include also therapeutic intent for cyst or abscess drainage, vacuum-assisted excision. Cysts are non-specific, and it may be asymptomatic, but when large size, it will be symptomatic, and when complicated by infection or hemorrhage. This will be the cause for drainage. Large cyst with anechoic or complicated with heavy internal echo and turbidity seen within. Ultrasound-guided intervention is now a preferred approach for management due to minimal invasive nature, easy accessibility, and shorter procedure time. It is associated with no significant scarring, need no admission, and breastfeeding does not need to be discontinued. Another intervention with the therapeutic intent include vacuum-assisted excision for the benign tumor. Here is the vacuum needle seen inside the lesion, only one incision, only one entrance, and multiple lesions, multiple part of the lesion is taken, which is done for the pathologically proven benign lesion less than 2 centimeters. Its advantage is no incision or scarring, and no need for localization of the non-palpable lesion. And last, intervention with palliative intent for drainage of the recurrent pleural effusion, as breast cancer is the most common cause of malignant pleural effusion. And to conclude, breast intervention is an expanding spectrum performed by the breast radiologist. It includes early diagnosis by biopsy and tumor localization with clip during radiotherapy and wire localization for the surgeon. Also, it includes therapeutic intent for aspiration or drainage guided by ultrasound and vacuum-assisted excision of the benign lesion. And even in late stage, palliative aspiration, palliative intent used for aspiration of the effusion. Thank you.
في حد any questions to Dr. Nashwa?
Yes, I have a question. أنا بس بالنسبة للانترفنشنال بس عشان ليكي في المحاضرات اللي جاية وبرزنتيشن انترفنشنال مش بس اللي انت قلتيه، في حاجات جديدة كمان ممكن نضيفها although انها لسه not well accepted worldwide اللي هو الابليشن ثيرابي في البريست ليجنز ودول بيبقوا يعني في ستاديز كتير اتعملت even على الكانسر patients اللي هم not fit for surgery, not fit for chemotherapy او refused السيرجري والحاجات دي. في الابليشن ثيرابيز سواء راديو فريكونسي او كرايو او ليزر whatever يعني to complete السيت اب بتاع البرزنتيشن. This is number one. نمبر 2 كنت نفسي تتكلمي برضو على الاكسيلري نودز في الانترفنشن وبرضو يعني whether to put a clip ولا بايوبسي، يعني فيها كلام كتير قوي، ممكن دي تبقى محاضرة لوحدها على الاكسيلا والابلكيشن بتاع الانترفنشن راديولوجيست في الاكسيلا. الواير يهمني برضو بالنسبة للي يشتغلوا لانه ده فيري فريكوينت بقى الواير، ان في التقرير بتاعنا لازم نحط دايجرام احنا فين، لان احنا يوجولي لما بنحط الواير بنحط البروب كده وبنخش فبيبقى الليجن بعيده شويه عن السايت اوف انتري اوف ذا واير، ودي sometimes بتبقى confusing للسيرجن. ف I would advise you beside after you finish the wire بنحط ink mark على السكين من بره كده just to guide the surgeon فين مكان التيومر عشان يبقى oriented بيه. وعشان اعمل كده لازم تبقى البيشنت نايمه في الوضع اللي هو السيرجن هينيمها فيه، اللي هي just flat on her back، ويعني زي ما بنقول كده just supine، ما تبقاش oblique ولا اي حاجه عشان ما يحصلش نوع من الديسورينتيشن بالنسبه للسيرجن في لما يجي يبص يقعد يدور على الواير. الحاجه الثانيه بالنسبه للواير برضو نبعت النيدل نفسها عشان ممكن يحطها ويحسها، لانه الواير بيبقى رفيع قوي للجراحين اللي هم ممكن مش كل الجراحين شاطرين واخدين على الواير، انما those who are not ممكن يحط النيدل التاني على الواير يقدر يبقى ستيفر، يقدر هو تو جايد ليه. وطبعا لازم ناخد ماموجرافيك فيوز عشان اوري الريليشن شيب between the wire and the clip او الواير والماس. وهنا يهمني اقول ان احنا في هذا الوضع ما بناخدش الام ال او، بناخد ميديو لاترال دايركت. بس these are comments بس حبيت ان انا اقولها لك يعني. Any further questions؟
هو الكومنت بتاعنا بقى ان احنا عندنا الجزء بتاع الار اف ابليشن ده في الجزء الرجالي في الانترفنشن. احنا عندنا التو ديبارتمنت، في انترفنشن بير سي وفي فيميل ايميجنج.
فعلا يعني
فيميل ايميجنج واخدين الجزء اللي هو بتاع البيوبسي والواير والكليبسات، والار اف ابليشن في الانترفنشن ان شاء الله هيجيبهم، يعني نحطهم جنب بعض.
انتوا يونيك، انا يعني بتكلم عموما على الانترفنشنال يعني anyhow. Okay, thank you. Thank you. See you.
Thank you, Dr. Nashwa. We are going to the last